You're listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is an academic medical oncologist at Dana-Farber Cancer Institute and instructor in medicine at Harvard Medical School. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today we're discussing immunotherapy for colorectal cancer, and Dr. Marwan Fakih is joining us. Dr. Fakih is a professor in the Department of Medical Oncology and Therapeutics Research and co-directs the Gastrointestinal Cancer Program, and is the Judy and Bernard Briskin Distinguished Director of Clinical Research at City of Hope. Dr. Fakih, thank you for joining us.
Well, thank you for having me.
Yeah, it's my pleasure. You've had an impressive and distinguished research career in GI oncology, and more recently, you've led several important innovations in immunotherapy in colorectal cancer, which is really exciting since this has been a cold tumor for a long time. Before we move to that topic, I'd love to hear a bit more about your path to becoming a GI oncologist and a successful investigator in this field.
Yeah, I think this is one area where I can say I did not really plan, to be honest with you. I've always had a passion as a medical student for oncology and initially, frankly, hematology more than oncology. But as I went through fellowship, I went towards the solid tumor route, and I was always interested in the diversity, complexity, integration of different specialties within oncology. But I would have to say my career moved toward GI oncology because I remained at my mother institute, University of Pittsburgh, as an assistant professor of oncology, and the opportunity came to work in phase 1 in GI at that point, and I fell in love with colorectal cancer, and from there on really kept steady at it and enjoyed every minute of it. So sometimes chance moves you in one direction, but for me that was a good direction.
Great. And it's been a successful one. So let's actually start with microsatellite unstable colorectal cancer. And this has been like the real success story of checkpoint blockade in GI malignancies. And I thought we could maybe start at the bottom and we'll move our way up. So just as a way of organizing things. So about a year ago, we all heard the impressive data published in the New England Journal of Medicine by Dr. Andrew Sursek from Sloan Kettering using dostarlimab for localized mismatch repair deficient rectal cancer. It was a small phase 2. But many call this a practice-changing result, and I'm curious to hear your thoughts on these data and now how you treat mismatch repair deficient localized rectal cancer based on this information.
Yeah, what a success story, right? Between that particular trial and the niche trial looking at MSI-high colorectal cancer with localized disease, you don't need many doses of immunotherapy to get the tumor to shrink away. I think while all of us love to see confirmation with larger trials, the reality is that patients with rectal cancer with MSI-high disease do need better treatments. And when we think about immunotherapy and sphincter saving, avoiding surgery, avoiding radiation therapy, for many of us, do we want to wait another 5 years to offer those strategy to our patients? And the answer is, in my opinion, no. I think we have to have that discussion, a 20-patient trial or less or more with a 100% response rate coupled with supportive data from the niche trial showing a very high complete pathological response with only 4 weeks of therapy prior to surgery, can't be really ignored. And I think our practice has changed. We don't start chemoradiation or chemotherapy without knowing the MSI status for localized rectal cancer, because we know that the discussion related to immunotherapy should be on the table with those patients. And whether we decide at that point to use this off-label or not is a different question.
Yeah, so rectal cancer does seem like a place where it seems kind of clear we should move forward. What are your thoughts on the niche study? Are you incorporating that into regular practice, or for a laparoscopic resection where maybe the morbidity of surgery and the outcomes are better? Are you routinely offering checkpoint inhibitor therapy neoadjuvantly for those patients, or are you still thinking in a more conventional resection adjuvant chemotherapy pattern there?
So first, the reality is that patients with rectal cancer with MSI-high status are very rare and far in between. And I think it's no more than probably 2% of our general population because they tend to be more the Lynch syndrome patients rather than the MSI high sporadic hypermethylation. When I see that rare instance with rectal cancer now, I think I do discuss upfront immunotherapy in those patients, and it would be an off-label discussion, obviously. I don't think that I am at a point where I would suggest that for patients with colon cancer. I think even though the niche trial is extremely exciting, but the reality is the data is with a doublet. There is the issue of, a lower morbidity surgery in this right-sided colon cancer where you recover quickly from a laparoscopic right hemicolectomy, and you avoid, even though rare, the potential significant IO toxicities in some of those patients, and not to, forget the need for more frequent endoscopic evaluations if you decide to proceed with immunotherapy only for colon cancer. So I don't think we're there yet to offer patients with colon cancer immunotherapy as the only treatment modality for localized colon cancer. Rectal cancer may be different for me, and I think in that setting, it's a life-changing experience when you go with chemoradiation and surgery, not to the, unfortunately, not for the good, right? Low anterior resection syndrome, lifelong bowel movement changes, urgency, frequency, etc.
Yeah, I mean, I think that's an important distinction, right? Rectal cancer, where the symptomology of treatment is very different than colon cancer, and the surveillance is different and harder. You touched on single agent checkpoint inhibitor versus doublet and the differences between them just briefly there. And that actually makes me think about advanced disease. So when we think about mismatch repair deficient advanced colorectal cancer, we really first saw checkpoint inhibitors. How do you balance the risks and benefits of, say, Pembro versus Ipi/Nivo, and when do you reach for one versus the other?
Yeah, like many of us, I do struggle with that decision because I don't think there is a right answer. I mean, we don't have today a definitive biomarker that tells us who is a patient who's less likely to respond with MSI high metastatic colorectal cancer to immunotherapy, although there are some leads. For example, there are some data suggesting that diffuse carcinomatosis with ascites may be associated with a lower response to immunotherapy. We have previously shown that TMB within MSI high colorectal cancer may be indicative of a response. And when we see patients with an TMB of 25 or 28 or 19 with MSI high, those are less likely to achieve a complete response, even an objective response. And so if I do see a TMB of 30 or 25, I personally would rather go with a doublet based on some of the data we published previously. And obviously, if I have somebody with multi-organ involvement, there's some suggestion that liver metastases may have a little bit lower response, not just peritoneal metastases. And in that particular setting, I may still favor a doublet in a younger individual with bulky disease. I have to say this is not scientifically supported today by a wealth of data. That's just a pattern of practice that I have undertaken. I certainly have many patients who've had a complete response and came off pembrolizumab and are years now after completing, even 1 year or sometimes 8 months, 10 months of treatment with pembro, not necessarily 2 years, who never relapse. So over-treatment is still on my mind, and I still find myself using more single-agent pembrolizumab based on the phase 3 Keynote 177 rather than proceeding with Nivo/Ipi in the majority of my patients.
Mm-hmm. And how do you surveil your patients when they're on treatment and off treatment, when they have no measurable disease? I always really struggle with that process.
And not only that, it's even more complicated because you may have measurable disease that is completely fibrotic and dead. And so, we may be over-treating some patients if we rely completely on CT scans, because we've had many patients where we start them on pembrolizumab and they'll have a liver metastases, we take them to surgery, and it's a complete path response. And even though they do have visible measurable disease on CT scans. So number one, you have to be aware as a provider that a CT scan underestimates the complete response to therapy. And I think the reported complete responses in the literature of 10 to 20% with pembrolizumab monotherapy, in my opinion, and based on what we see in our practice, are likely an underestimation of the complete path response rate in these patients. And so we do rely somewhat on ctDNA in our patients, and that's a very good biomarker of response to immunotherapy to make sure that you're not missing a pseudoprogression early on. So we tend to get, ctDNA at baseline and monitor. And if somebody has a complete ctDNA response and has an excellent response to imaging, and you still have a little residual disease by imaging, sometimes we rely on a PET scan to make sure that this is, metabolically active or non-metabolically active. Even with someone with a little residual measurable disease with a PET negative status, ctDNA negative status, I may kind of consider those more as a clinical complete response, in my opinion. And some of those patients we monitor. And so I would say, as far as monitoring a complete response, I do scans every 3 months, CT scans typically, if they don't have any measurable disease. I do that for a couple of years, and then after that, I do it every 6 months, and I monitor for years to come. I don't know that the 5-year mark that we've used to with stage 3 disease is the right thing here, and I tend to, after 5 years, do at least a yearly scan on those patients. I think I want to monitor them a little bit longer.
It's funny, without data, we all seem to end in a similar place. I have this handful of patients, the same deal, where we're beyond 5 years. I remain nervous. One of them has what looks like measurable disease, but it's maybe a fibrotic node. And I still feel obligated to scan her every year. But we're only 7 years in, so I don't know. We'll see what I think at 10 years. But it's a real challenge. It's an exciting problem to have. Now, checkpoint inhibitor therapy and immune therapy for mismatch repair deficient colorectal cancer is critically important. And as you pointed out, in rectal cancer, it's quite rare. And even advanced disease, it's quite rare. And the elephant in the room in immune therapy for colorectal cancer has been microsatellite stable disease, especially microsatellite stable advanced disease. So I thought we could move to that. And I think that's a very exciting topic, and a topic where you've really had a leadership role throughout the world on this particular approach. So, the road traveled by checkpoint inhibitors has been bumpy and largely ineffective. We've had failure of ipi-nivo and durvalumab. The FOLFOX bevacizumab nivolumab first-line study was a negative study. Even the GI-002 neoadjuvant rectal cancer study, I think by and large we could call negative. The list is long, but now we're seeing some successes. So I want to start with the ipilimumab, nivolumab, regorafenib combo that you recently published. So how did you come to this? What would you like us to know about this combination? How do you think about this? And maybe can you talk a little about the synergy of TKIs and immune checkpoint inhibitors? Is it real? Do we believe it? I'd love to hear your thoughts.
Yeah, definitely. So my interest was sparked initially, like all of us, by the Japanese data on Rigo-Nivo that was published in JCO, and at that time was like, 35% response rate. And I have to say, like many other investigators across the country, we've used it off-label. One thing that I've noticed as I've treated my patients is that I've never seen a liver met respond, but I was seeing some patients with lung metastases develop responses to Rigo-Nivo. We conducted the phase 2 trial. Bayer supported that large phase 2 trial that I served as a principal investigator on with Rigo-Nivo in the US. And obviously the response rates were less than 10% in the overall population, but it confirmed what we had previously reported in a series from our institute, that liver mets didn't respond. There were more than 40 patients who did not respond, who had zero response rate with liver mets, and the response rates in patients without liver metastases was 22% with regorafenib nivolumab. Now, I do think there's synergy there because, as you said, the durva-tremi data is completely negative. There was one responder on that study and was a lung met patient. But, still, it's no more than 70% of that large study had liver metastases, and yet the responses were not 20% in those patients. And previously, with all the studies with Pembro, with Nivo, we don't see that big signal with PD-1. Maybe you'll see some stabilizations, but not responses. So I am convinced that the TKIs do add something, and we do see a little bit more immune kind of flare with the skin toxicity that is not explained with Rigo alone, as if there is some kind of immune activation early on. And interestingly, when we looked at Rigo-Nivo, there was some correlation between that particular toxicity and a little bit higher likelihood of response. So based on the Rigo-Nivo data, we said, well, yeah, there's a signal, but how can we accentuate that signal? And I have to say that there are no great preclinical models. So the whole idea of adding IPI there was like, hey, CTLA4 induces an immune response in a different way than PD-1. It's synergistic in many other tumor types. It appears to have a little bit higher response in MSI high CRC. So why not give it a chance and add a CTLA-4 to PD-1 inhibitor in the setting of a TKI and see if we can accentuate the responses? So we did a single center clinical trial, 39 patients, 29 patients treated at the recommended phase 2 dose. And in those 29 patients, obviously based on our experience, we enriched those patients with non-liver mets, and 7 patients with liver mets had no response. 22 patients without liver metastases had an objective response rate of 36%. And when we look at iRECIST, we actually had a 40% response rate. And out of those 22 patients, 6 patients out of 22 at the 2-year mark had no progressive disease. And some of them now are being followed again without any therapy, without any evidence of disease progression. So these are things we haven't seen with Rigo-Nivo before to that level. We haven't seen with PD-1 inhibitors alone. And we know from prior data with Trem immunotherapy, it doesn't also work in colorectal. So we do believe there's synergy, and that's in line with additional data that has been shown by Janus Bio on the botensilimab, balstilimab combination.
Yeah, and that brings us to a great next topic, which is botensilimab and balstilimab. This is the second generation CTLA-4 inhibitor with a PD-1 inhibitor from Agenus here in Boston. You participated in that phase 1 trial, as did I, and you're now, I think, leading the enrollment in the phase 2. So talk to me a little about your experience with that combination and the toxicity profile, the efficacy profile, and how it compares to regorafenib with ipilimumab and nivolumab. I'm curious to hear your thoughts.
Yeah, I mean, to me, the exciting thing about botensilimab, balstilimab, so botensilimab, as you mentioned, is a second-generation CTLA-4 Fc engineered, and it appears to be more potent in stimulating the immune system than first-generation CTLA-4 inhibitors. I mean, there's been no report previously on a combination of a CTLA-4 PD-1 or a CTLA-4 PD-L1 with such robust responses. And, I think this could be potentially game-changing. The response rates reported on a couple national meetings now are more than 30% in patients without liver metastases. And the patients without liver metastases, the median progression-free survival has not been reported yet on this study, with many patients without liver metastases having ongoing objective responses without progression, more than a year after initiating therapy. So I do think we're looking at a different class of CTLA-4 inhibitor here that may be potentially game-changing for patients with MSS. It does also confirm our prior findings that liver metastases are different. And we've shown that the tumor microenvironment in liver mets is completely different than lung mets. It has a different, infiltration B cells and T cells and spatial distribution. But that's good to know, because now you kind of use the drugs that work in the patients where you expect those drugs to work, and you focus on the liver metastases and understanding how to target those in a different way. So I'm excited about that. It does appear to have, colitis as an associated toxicity, but there are ways to mitigate those or to address them if you catch them early. And I think a lot of that is happening now on the phase 2 trial, and this is going to be a phase 2, a key study to confirm a differentiation of these two drugs and support a much higher efficacy than what's available as far as standard of care.
And now for our listeners, if you are treating a patient and you don't have access either to the botensilimab, balstilimab trial or other similar investigations, you have, say, a fit patient with no liver metastases, only peritoneal or lung disease, for example, or nodal disease that's non-resectable, do you think there's a role for off-label use of RIN? Is this something that people should be pursuing, not ready for prime time? I know it's always a hard question to ask about doing things off-label, but I'm curious to hear your thoughts.
Yeah, I personally think those patients should seek a trial. I mean, I think the RIN is an effective regimen, but the reality, it's still a small number of patients. It's a single institute trial, and these patients can have toxicities still. And so I think we need to collect that data. And, we presented data at AACR that when we looked at patients treated with RIN and Rigo-Nivo with peritoneal carcinomatosis, we didn't see a response. And, granted, those were only like 7 patients, but that's why it's very important to understand the pattern of metastatic disease. I think lung mets are going to respond differently than soft tissue metastases, which will respond differently than peritoneal carcinomatosis. And we're doing our best to kind of report the data that we have collected on almost 100 patients treated with TKI, PD-1 combinations or TKI, PD-1, CTLA-4 inhibitors. But I would personally, even in my practice, I enroll those patients on study.
Good. And so what's the path forward now, do you think, with immune therapy? Are we going to be focusing on the addition of liver-directed therapy? What other agents, novel interventions? What do you see over the next few years?
I think for liver metastases, personally, I think the question is going to be, is it oligometastatic disease? Is it diffuse metastatic disease? Once we confirm that the extrahepatic metastatic disease work beautifully with a certain IO combination, the next question is going to be, if you have liver-limited disease, can you take care of it surgically or by ablation if it's only 2 lesions, and render this patient an ED in the liver? And if they are, could they be candidate for IO as well? There's no question we've seen patients with hepatectomy who have beautiful, durable responses with REN, and some, frankly, with Rego-Nivo. But I don't think that if you have somebody with 10 lesions in the liver, you're suddenly going to change the biology of liver metastases. So there is a lot more to understand, as to what to do with those patients. But at the same time, there are other immunotherapies. You've got CAR T cells coming online. You've got TCRs coming online. And I think those may also be game changers, hopefully, for metastatic MSS-CRC, maybe irrespective of the location of the disease. So we've got to look at all those tools.
Yeah, that's fantastic. And thank you for that insight. Obviously, we're all optimistic about this. There's a lot to discover. I'm looking forward to reading what you have to write and listening to what you have to say about this over the coming years. That was a really great discussion, so thank you again. Today, we discussed the use of immune checkpoint blockade in colorectal cancer with our guest, Dr. Marwan Fakih. We talked about strategies to use this in localized rectal cancer, where it seems like there was a practice-changing result with the data on dostarlimab and emerging data on neoadjuvant therapy in the niche study with ipilimumab and nivolumab. And we also talked about the use of pembrolizumab versus ipilimumab with nivolumab in advanced mismatch repair deficient disease. We also touched on emerging data using dual checkpoint blockade with either TKIs or novel second-generation CTLA-4 inhibitors. And we're waiting for mature data on that, but we think that a lot is coming here, and it's an exciting time. So thank you so much for joining us. This is Dr. Benjamin Schlechter for In Discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.